Vanshi, for giving us opportunity, and then thanks to Rajiv putting a very good background and creating a solid foundation. What we are going to talk today about halting progression of chronic kidney disease, which is a myth or a reality. Most of the work already he discussed. The myths have been that kidney disease is rare. It's not true. It is ninth leading cause of death in the US. Another myth is there is nothing you can do about getting kidney disease. Most cases of kidney disease could be prevented, and that was the purpose of today's presentation. Another myth is you would know if you had a kidney disease. Certainly, yes, there are certain markers, though initial part there are no symptoms. Dialysis is a cure. No, it's not a cure. It's another replacement therapy for the time being till you get your another transplant. And kidney stones causes disease. It is, but then it is reversible and it can do a permanent damage, and you need to treat and know the etiology of the disease. One of the reasons why it takes little longer time is because of the progressive nature. Stage 1, there would be patient would be absolutely normal, may not know about it. Stage 2 onward, it's the blood pressure and the protein in the urine which makes him aware. It's anemia, bone disease later on, and fatigue, vomiting, which makes him sick, and only then he visits to a doctor. So there is no cure. Certainly there is no cure, but then at the normal function, it's only the awareness. Stage 2, between the 60 89, that's the time when patient comes with the blood pressure, control of diabetes, weight loss. Stage 3, there's a moderate decrease. But GFR starts now, and this is the time when patient would be accidentally discovered having creatinine high, lower blood pressure. We need to control the diabetes. We need to look at the fluid restriction, prevent malnutrition, and uremia. Stage 4, disease is severe. Now patient goes to clinician. Now patient goes to doctor, cares about his symptoms. Stage 5 is now when we need a replacement therapy in different form. What are the risk factors which can stop the progression and halt it? You cannot do with modified factors like age, male, oligonephronia. I think Raju did talk about the how many number of nephron you are born with. If you are born with a little nephron, this is the Bricker's intact nephron hypothesis, and Brenner's hypothesis, how many nephron working you have. And if you have a less number on nephron, you are likely to develop insult much quickly. Hereditary factor, Alport's disease, many other. What are modifiable condition? And everybody has been talking since this morning: diabetes, blood pressure, autoimmune disease, inflammatory condition, infections, urinary tract, obstructive neuropathy, drugs, and the diet, smoking, and obesity. The tubular interstitial versus glomerular disease. Tubular interstitial present more as the incapacitation in the form of edema. The patient could have a metabolic disease, could have a thyroid dysfunction, could be a calcium dysfunction. Glomerular disease make you visit doctor early because of the hypertension, massive sodium and water retention, blood pressure, proteinuria, intraglomerular hemodynamic factors, and diabetes. This has been there since 1993, and we knew that microvascular complication can be stopped with a very good control of diabetes in type 1 diabetes patient. But we also understand now that the earlier referral to the patient and look at the serum creatinine value and look at the demonstration of slow CKD progression would make person to get the diagnosis and intervention early from the baseline to the steady cohort. Diet has been now become very popular, and if you look at the Google, you would get so many articles, but the key question remains always about the alkali intake, decreased sodium intake, decreased potassium intake, and decreased oxygen intake. All these could lead to, and there are different papers available, but what is important to know is that the non-vegetarian diet adds to more urea turnover and the creatinine turnover. So there are all now indication consuming protein less than 0.8 gram per kg body weight in an established patient of the CKD stage 2 is going to halt the progression. And this is the recommendation. This is a busy slide. I would like you to concentrate on this energy, 25 to 35 kilo per calorie per kg, and look at the sodium consumption. And ultimately, when patient reaches to chronic kidney disease, in the field of replacement therapy like hemodialysis, peritoneal dialysis, one becomes little liberal in food because appetite becomes better with hemodialysis, maintenance hemodialysis. Phosphorus should be reduced. Calcium should be less than 2 grams per day. And then fluid should be restricted according to the diet. This I was talking to you about the alkali, and look at the looking at the albumin creatinine excretion, and when you do dietary acid control, then it also decreases your protein albumin over the period. This is the question related to obesity. What I talked to you, pre-dialysis, you need to take care of obesity in these patients because they have a high risk of CKD progression. During dialysis, also obese patients have a problem. It is the interdialytic weight gain which leads to decide the prescription of what should be the ultrafiltration and what should be the required hours of dialysis. Of course, in transplant also, obese patient may be excluded from the kidney transplantation program because they have a survival disadvantage. And therefore, obesity is an important factor in deciding the progression of kidney disease. Second is anemia. And we know now because erythropoietin is low, leads to anemia. It induces, and this was being talked before with Dr. Rajiv also, this is a cardiovascular continuum, that increased progression of renal disease, decreased renal perfusion, decreased filling pressure, heart failure, cardiomyopathy, and myocyte death. Last part is important because even chronic kidney disease, like diabetes, independently can lead to cardiac myocyte damage, hence would enhance the progression and decrease the EGFR. There have been landmark trials for anemia, and we now understand that the 3 drugs we have used, initial improving the iron, then going to the roxatate, we'll talk in a moment, and then looking at the erythropoietin, and the last looking at the hemicidine, which is an important factor in treatment of the anemia. Therefore, it is the insufficient production of endogenous erythropoietin, iron deficiency, inflammatory condition which increases hepcidin and therefore tries to retard the release of iron from the macrophages. Hyperparathyroidism is another component which needs attention, and you treat it and it's completely reversible. Albumin toxicity as well as hemoglobinopathies all add to deterioration of renal function. IV iron is important, and whenever we plan now to treat these patients, it's better to look at the IV iron preparation. They significantly reduce the erythropoietin requirement in dialysis patient, and is an important component also to halt the progression of the kidney disease. I talked about roxadustat. Now this is what I was referring to you. This is again hypoxic induced fat factor inhibitor, and when we use roxadustat, it effectively, this is the 2016 publication about 107 Japanese patients, dose dependent increase in hemoglobin, and no miss occurred in roxadustat group. And therefore, it is another addition to retard the progression of anemia and CKD. This is when you use dark erythropoietin than the erythropoietin. And still the old is good. And there are about 10 studies available. And this is the review meta-analysis which have shown that either you use, they both have a positive factor, but dark erythropoietin have got least chance. Conventional erythropoietin has some inbuilt problem. And we know about the problem of the malignancy. We know about the conversion as well as aplastic anemia subsequent time. There was some paper, and therefore the dark erythropoietin have got least toxicity, least chances of hypertension, least weight gain, and edema. I was talking to you about the hepcidin, and this is an important component which regulates transferrin and at the increased erythrocytes level, and this is blocked with the chronic persistent inflammation as well as ongoing inflammatory insult, as well as the most of the inflammatory factors, pro-inflammatory factors at the level of the endosome. And treatment of this hepcidin inhibitors have got a role. Dr. Rajiv also talked about the management of the blood pressure, and this is important because the problem with the chronic kidney disease is as the systolic blood pressure increases, the renal blood flow tends to decrease, and because of that, there is also increased problem in intraglomerular hypertension. And when you use a drug, you try to do vasodilatation. There's improvement in the renal blood flow. According to systolic blood pressure also, increased GFR, massive proteinuria with the renal damage is directly proportionate to the systolic blood pressure. So control of blood pressure would not only take care of the albuminuria, would also retard the renal damage and would also retard the progression of GFR. This slide I got it for the reason, look at these squares. Yeah, these are the black square. This is the dihydropyridine CCB, and these are the stars are the ACB and ARS and the RAS blocker, and the white are the empty one are the uncontrolled. What is said that if you reduce the blood pressure even with traditional old calcium channel blocker, dihydropyridine, they would also decrease the incidence of glomerular sclerosis. This is not old, very old paper. This is hypertension paper and published in Kidney International. And this is the paper only published into 2017. So this paper is still says 2007, 4-year back paper, that the traditional use of calcium channel blocker would also retard the blood pressure, would also retard the proteinuria, and would also retard the glomerular sclerosis. Therefore, when you try to take a decision, should you use AZ or ARB? Initial stage, yes, certainly you should. But if the serum creatinine value is less than 25%, you need to monitor. If it is more than 25%, stop AC and evaluate for RAS. Otherwise, creatinine would go high. And this is one of the reasons why we do not recommend patients to use long-term unsupervised, especially in this country, for the hyperkalemia. Continue until the contraindication arises. No absolute GFR is cut off. Better proteinuria suppression with low sodium diet and diuretics. Avoid volume depletion because that would enhance AC and ARB toxicity. Do not use in the combination. Another problem is the hyperkalemia. I said you, and you have to be very, very cautious about it with the dietary as well as the use of furosemide. Now, this is another article which I wanted to show you. This is about the control of the systolic blood pressure proteinuria. These are the two parameters, and this is the highly significant. And the moment you use ACE, ARB, beta blocker, calcium channel blocker, whatever drug you choose to control the blood pressure, the systolic blood pressure reduction and proteinuria would decrease significantly. With dual RAS blocker, you do not get this advantage, and any other drug does almost same thing. So it is still better you have a chance to use either drug, looking at the rationality of using beta blocker, calcium channel blocker according to the guidelines. These are the huge study, and they try to compare between the ARB and ACE. And when you come in relation to the reduction of proteinuria, ACE inhibitors are still better. They are still better than the control. When you come to the progression of the ARBs, then ARB is better. Overall, if you look at the numbers on both sides, ACE inhibitors score much, much better in controlling the regression of proteinuria and then the referring to the hypertension. This is the short and long-term use of the, we are talking in relation to this is 2012 publication, a systemic review which have talked about the use of the bicarbonate, and this is in fashion now. This was in our time in initial training, this was very favorable, but then somehow this was dropped. But now again, the sodium bicarbonate use is prompted, and this has led to regression of eGFR initial part. Allopurinol, another one, and we know now urates, and we know the hyperuricemia. Initially, we thought that hyperuricemia is a consequence of decreasing eGFR, but now today we understand if you need to reduce it, and if you treat it, the hyperuricemia with any drug, whatever you have, whether you use faboxate, whether you use allopurinol, then certainly it would try to enhance the eGFR and would also decrease the progression of the sclerosis. And this particular paper looks at the, if you look at the bottom line here, the last one, fatal or non-fatal cardiovascular event. This is in relation to the allopurinol. This drug And look at point 7, this is about 21% favorable in decreasing the progression of EGFR when you are using allopurinol. And this is in relation to those patients whose EGFR was less than 30% decrease and 40% decrease. Thereby, you have a fair chance of using these drugs even in those patients who are getting into the CKD. Polycystic kidney disease. And now we understand that tolvaptan, though this is a costly drug for Indians at least, but then it has a potential to decrease the progression and decrease the volume of the cyst and the kidney size. And this is another paper. Everolimus, which is mTOR inhibitor, could be also used in the regression of polycystic kidney disease. Then looking at the glucose control, and this has for last 2 days we have been talking about all it. It also again depends on the EGFR. If even in the CCT trial when we used glucose lowering insulin, and we know that at that time we knew it that these would retard a good glycemic control. Whether EDIC study subsequently showed us that we can sustain our EGFR less than 60 in a 50% number of patients. So it's a huge advantage of not only retarding the microvascular complication, but also macro and also sustain EGFR. And this is the EDIC trial 1 to 8 years, which have again shown microalbumin reduction 54%. Macroalbuminuria, micro is 59%. Significant finding. No talk is complete without the SGLT2 inhibitor, and you all understand. But what word of caution? Dapagliflozin they used at the initial study with 60, when Dapagliflozin they used almost up to 30. EMPA also used more than 30. Canagliflozin also used more than 30. And they have been able to show the advantage in reducing and sustaining the EGFR. Look at the value composite, 40%, more than 40% decline, and the progression up to 45, and renal replacement therapy or up to the 60% decline. So we have all the advantage of using these drugs. And look at the hazards ratio: canagliflozin 40%, empagliflozin 46%, and then 43%. Cana stands much better, and you have seen since this morning. And this is another study which was done by Empiric, and also have shown that it is a renoprotective effect independent of concomitant medication that you are using for the hemodynamics. Invocana, again, the same study shows 30% risk reduction. And this is the, again, comparative study. What is important here, look at the bottom point here. All these drugs, this is here 0.61, so this is about 49, 59, 49%, 28%, 38%, 26%, all these three gliflozin with a difference of 5 to 10% deviation have shown that there is an advantage in sustaining the EGFR. But what level you use, and look at the bottom, you should not less than 30 ml per minute. And this is the important information to all of you, to most of us who are still provocating. And we have seen time and again, even during COVID time, that if you continue to use unsupervised use of the gliflozin, even during COVID time, then there is a problem, and patient can go into acute kidney injury, and serum creatinine can go high, EGFR will go reduced. This is the 2021 publication, Kidney International, and look at the bottom. I wanted you to make it aware that it is a DAPA-CKD study. At the bottom, it's very small writing, but I cannot make it larger because of the technical reason. They have shown the advantage, tremendous advantage, about the 39% sustaining in EGFR rather than any other gliflozin, and this is in relation to various outcome trial. Somebody was talking about the sclerosis. Perfendon, which was being used to decrease the fibrosis in the lung, also had been used to decrease and have shown a beneficial result in sustaining the EGFR, decreasing the glomerular sclerosis. Then this is again another study published in New England Journal. This is 2020, only last year publication, which have shown it lowers the risk of CKD progression in cardiovascular event than the placebo. And this is the urinary albumin excretion. This is another drug, avocentan. This is avocentan is a molecule which is the endothelin receptor antagonist ET1 and shows the decrease into the albuminuria, also in progression of the diabetic nephropathy. Pentoxifylline. We published this paper in Nephron about 1984. But then it keeps on coming, and there are a group of the patients, especially where there is a decreased rheology, diabetic own food, and they are not improving. Use of pentoxifylline also significantly reduces proteinuria, improves rheology, improves intraglomerular hypertension, and tries to preserve CKD. This last one slide, you must be very cautious of using nephrotoxic drug like radiographic contrast, aminoglycoside, lithium, calcineurin inhibitors, and because of those patients who have multiple complications in ICU or CCU, or they are into the tertiary care with multiple problem, metabolic conditions, surviving for longer time, prescription must be screened for, and you should try to prevent it. Therefore, to summarize, halting progression of CKD is a reality and not a myth. Early detection and prompt treatment would try to do some justice with the halting the progression. Dietary and obesity management is equally important, and you have seen the slide that they are important not during the progression of disease, but also during the treatment and transplant as well as the dialysis therapy. Strict BP reduction. I told you, even you use calcium channel blocker, traditional blocker, they do this good job, and you should use them judiciously, rational and early use of ARB and ASI. And I must mention Dr. Mani from Chennai, very, very old octogenarian now, he must be about 90. He used even adelphane as a drug. He published the article in Kidney International. For some reason, this did not gain the light because of the industry did not support it. But he used adelphane, one of the very old antihypertensive drug which we wrote initially during our training time, and over the 10 years have retarded the incidence of the CKD in patients who had hypertension. In diabetic strict glycemic control, SGLT2, GLP, RA, antifibrotic drugs, mTOR modulating drugs have a role. Early referral to the nephrologist is necessary. And last, avoid the nephrotoxic drug. Thank you very much.